Okay, let's dive in. As specialist clinicians, we know that any powerful therapy we use, well, it comes with potential downsides. Hyperbaric oxygen therapy, or HBO2, is no different.
Hmm.
Really understanding those risks, the what, the how, and, the how often is just as fundamental to providing exceptional patient care as knowing the indications and expected benefits inside and out.
Absolutely. It's easy to focus only on the incredible things HBO2 can do, but a complete picture requires a deep understanding of what can potentially go wrong.
Right.
Today, we're dedicating this deep dive to those known and potential side effects.
And we're doing this by immersing ourselves in a truly authoritative source. Excerpts from an expert chapter on this very topic written by, well, leaders in the field. Our mission for this deep dive is to take this expert material and really unpack the most important clinical insights it provides. We're not just reading it. We're exploring every significant fact, mechanism, guideline, area of controversy, and clinical pearl described so you, our specialist listener, get a comprehensive and actionable understanding directly from this foundational text.
Think of this as pulling back the curtain entirely on the risk side of the HBO2 equation, guided by this expert resource. We'll structure our conversation around the information presented in the source. First, looking at side effects caused by the effects of pressure, then moving into those related to hyperoxia, and finally covering other important considerations discussed in the text.
Perfect. Let's start by grounding ourselves in the basics the source lays out regarding these potential issues.
The fundamental premise is straightforward, as the source material states. Just like any medical treatment, hyperbaric oxygen therapy has potential side effects. It is not a risk-free modality, and acknowledging that is, the first step to managing risks effectively.
And the clinical setting itself is a practical consideration here. HBO2 isn't administered in just one way. It's provided in different chambers, monoplace and multiplace, by providers and staff with varying levels of specific hyperbaric expertise. That variability in the environment and personnel is important context when we think about the practical aspects of monitoring for and managing a side effect if it occurs in real time.
Precisely. And this highlights why that thorough understanding we mentioned is so crucial for practitioners. Knowing these potential side effects allows us to accurately weigh the risk-benefit profile for each patient, tailor our approach, and have a truly informed discussion with the patient, considering or undergoing treatment. They need to know what might happen and what signs or symptoms they should communicate.
To truly grasp the side effects, we need to be clear on the core definition of HBO2. The source defines it as the treatment of patients with 100% oxygen at higher than atmospheric pressure.
And the source details the two main chamber types, which is key context. Monoplace chambers are designed for a single person and are typically compressed entirely with oxygen.
Right.
This means the air surrounding the patient's whole body inside the chamber is 100% oxygen.
In contrast, multiplace chambers are larger, accommodating multiple people. These are generally compressed with air, and the 100% oxygen is delivered to each patient individually via a hood or a mask.
Exactly. So in the multiplace setting, the patient's body is surrounded by air at pressure while they breathe pure oxygen. In a monoplace chamber, the entire environment is oxygen at pressure. That distinction in the gas surrounding the patient's body becomes particularly relevant when we discuss certain side effects, notably those affecting the eyes.
And here's where the benefits and risks are intrinsically linked, a point the source makes clear. The beneficial effects of HBO2 stem from primary mechanisms, the direct impact of increased pressure, and the high concentration of oxygen, and secondary mechanisms, which involve controlled oxidative stress mediated by reactive oxygen species, or ROS, and reactive nitrogen species, or RNS.
The source highlights that these reactive species aren't just harmful, they act as beneficial mediators in various healing processes. But, as the source points out, these very same mechanisms, the direct effects of pressure and hyperoxia, and the downstream effects of these reactive species are also the origins of the potential side effects of HBO2, including different forms of barotrauma and oxygen toxicity. It's truly a double-edged sword where the therapeutic action potential also carries the potential for adverse effects.
It's the core challenge of leveraging these powerful physiological shifts. All right, let's transition to the first major category of potential side effects discussed in the source, those directly resulting from the effects of pressure.
Right. Several hyperbaric oxygen therapy side effects are directly caused by the body's response to changes in ambient pressure. The fundamental physical principle governing this phenomenon is Boyle's law.
Boyle's law, stated in the source. The pressure of a gas is inversely proportional to its volume, assuming temperature stays constant. You see the formula, P1V1 equals P2V2.
Clinically, this means something very important and very practical for us. As you increase the pressure around a gas-filled space, the volume of that gas decreases. Conversely, if you decrease the pressure, the gas volume expands.
Like a balloon.
Exactly.
Yeah.
Think of a balloon in a high-pressure environment gets smaller. As the pressure drops, it puffs up. If you could visualize Figure 1 from the source, you'd see that exact concept depicted.
And our bodies aren't solid. They have air-filled cavities. So these pressure changes directly impact those spaces throughout the body. The source lists the primary examples, the middle ear, the paranasal sinuses, and what it calls pathologic air spaces, which could be anything from air trapped in a dental filling or an old surgical pocket to air spaces within diseased lungs.
Exactly. And among these, middle ear barotrauma is arguably the most frequently encountered pressure-related side effect.
Let's explore that in detail, as covered in the source material. The middle ear is essentially an air pocket located between your external auditory canal, where sound waves enter, and your inner ear. Key anatomical components mentioned are the tympanic membrane, or eardrum, which separates the middle ear from the external canal, the round window, part of the barrier to the inner ear, and the eustachian tube, or ET, connecting the middle ear to the back of your throat, the posterior pharynx.
The critical functional point the source emphasizes is that the eustachian tube is normally closed. To equalize the pressure in the middle ear with the changing pressure outside, it needs to be actively opened.
Okay.
The source lists the common ways we do this: chewing, swallowing, yawning, or other movements of the jaw, and particularly relevant in the hyperbaric setting, the Valsalva maneuver.
And the source describes the Valsalva maneuver precisely. It involves taking a breath in, then attempting to exhale while keeping your nose and mouth or your glottis closed. This action actively opens the eustachian tube and increases pressure inside the middle ear, allowing air to move in during compression.
Right. Middle ear barotrauma, or MB, specifically happens during the compression phase of HBO2 treatment. It occurs when the eustachian tube isn't actively opened successfully.
Because the tube stays closed while the pressure outside the eardrum is rising, a pressure differential builds. The pressure inside the middle ear becomes lower than the increasing pressure in the chamber.
Yeah.
Boyle's law tells us that lower internal pressure combined with higher external pressure causes the middle ear volume to contract. This pulls the tympanic membrane inward and causes trauma to the delicate middle ear tissues.
And the source explains why you generally don't see MB during decompression. During that phase, the pressure differential reverses. The pressure inside the middle ear is now higher than the decreasing outside pressure. That higher internal pressure actually causes the eustachian tube to open passively, making equalization much easier and less likely to cause trauma.
Clinically, the most common symptom a patient will experience is pain. The source details how this progresses with increasing pressure differential. Initially, just inward retraction of the eardrum, leading to capillary dilation and swelling. As the pressure difference grows, transudative fluid can leak into the middle ear space. Further increases can rupture blood vessels, causing hemotympanum visible blood behind the eardrum. In severe cases, a large pressure differential can even cause the tympanic membrane to perforate or tear. You can visualize that progression from, a subtle discomfort to significant damage.
For evaluation and documentation, the source mentions two systems. The traditional one is the TEED score, originally from the U.S. Navy in 1944 for divers, not specifically HBO2 patients.
Right. A bit dated for this context, maybe. More commonly used now is the modified TEED score. So this score grades the findings seen with an otoscope. Grade 0 is normal. Grade 1 shows diffuse tympanic membrane redness and some retraction. Grade 2 has slightly hemorrhagic areas within the tympanic membrane.
Getting worse.
Grade 3 shows grossly hemorrhagic areas within the tympanic membrane. Grade 4 is hemotympanum blood clearly visible within the middle ear space. And Grade 5 is tympanic membrane perforation, a tear in the eardrum.
The source also introduces the O'Neill grading system designed specifically for HBO2. This system requires equipment to capture and save a baseline image of the tympanic membrane before treatment. Subsequent grading is based on comparing findings to this baseline. Grade 0 means symptoms but no anatomical change compared to baseline. Grade 1 is increased erythema from baseline, either in the TM or middle ear space. Grade 2 is bleeding within the TM or middle ear space. Grade 3 is perforation. and patients having trouble equalizing or reporting pain are reevaluated using this system with a new comparison photograph.
The key practical difference, then, is that modified TEED is a standard visual assessment against a generic scale, while O'Neill uses objective imaging and a patient-specific baseline for comparison. Makes sense.
Now, looking at the incidence of MB, the source confirms it's one of the most common side effects of HBO2. But the reported incidence varies significantly across studies.
Why is that?
Well, the source explains the reasons. How ME is defined. Symptoms, otoscopic findings, or both. Whether reporting is per patient or per treatment. Whether intubated patients are included. And which grading system was used. Most studies cited use the modified TEED score.
Okay, so what are the numbers generally?
The source provides incidence figures primarily based on the number of individual patients, unless noted otherwise. For conscious patients, the incidence ranges from 9% to 52%. If studies include both symptoms and otoscopic changes, it's higher, 32% to 52%. If only otoscopic changes are counted, it's lower, 9% to 19%.
That's quite a range.
It is, and here's a critical clinical takeaway. Among unconscious intubated patients, the reported incidence is dramatically higher, ranging from 23% all the way up to 94%.
Wow, almost guaranteed in some cases.
This population is at significantly increased risk for ME. The course also mentions that 5% to 15% of patients might eventually require tympanostomy tubes.
And while ME is common, the source emphasizes that the vast majority of cases are low severity, right?
That's right. 79% to 97% of patients who get MB fall into modified TEED Class 1 or Class 2. Higher severity, Class 3 to Class 5, is less common, seen in 3% to 21%, with actual tympanic membrane rupture being very rare.
Okay, good to know. So identifying risk factors helps in screening. What does the source say?
Pre-existing eustachian tube dysfunction is a key one, though the source notes it can be hard to identify before HBO2 starts. One screening method mentioned is checking for an immobile tympanic membrane with a Valsalva maneuver prior to the dive.
That's a useful clinical tip. And intubated patients.
For intubated patients, given their high-risk studies show double the incidence, the source makes a specific recommendation. Needle myomectomy is warranted when it can be safely performed in this population. This is a direct clinical guidance from the text.
Okay, what about other groups?
Patients with neuropathy also appear to be at increased risk, particularly for asymptomatic ME and potentially more severe forms.
That's tricky.
It is. This is a crucial pearl because pain sensation might be blunted. You need to rely more heavily on otoscopic inspection in these patients.
Makes sense. Any others?
Other factors that increase risk include older age, a history of head and neck radiation therapy, acute upper respiratory infection, and allergic rhinitis. These are all points to specifically ask about during your pre-treatment assessment.
What about the speed of compression? Does that matter?
There's been some investigation into whether the rate of compression, or ROC, affects ME risk, but the findings are conflicting.
How so?
The source cites one study that showed slower compression significantly reduced ME incidence.
Well,
But another study found no statistically significant difference in ME rates between ROCs of 1, 1.5, or 2 cm, suggesting 2 cm might be acceptable.
and multiplace studies.
Yeah, multiplace chamber studies looked at ROCs based on how many times the group needed to stop during compression. They found fewer stops with the slower 1.33 cm rate compared to 2 cm.
But how does that apply to a single patient in a monoplace chamber?
That's the challenge the source highlights. Translating these multiplace findings, where the unit of observation was the group, directly to a monoplace chamber setting is difficult. The optimal rate of compression for individual patients in monoplace chambers remains an area of, well, potential uncertainty or even controversy in practice.
Okay. Beyond RSC, what else can we do to prevent MEB?
Patient performance of the Valsalva maneuver to move the tympanic membrane is explicitly stated as protective. This simple patient instruction is often the most effective tool.
Good old Valsalva. What about medications?
The source notes that prophylactic use of nasal fluticasone and oxymetazoline are not effective in preventing MEB in standard HBO2 patients.
Interesting. Negative finding.
It is. And oral decongestants used by divers haven't been studied specifically in HBO2 patients, so that's an evidence gap.
What about those new devices?
Novel devices designed to help with middle ear equalization have also been studied. The source mentions the ear popper, evaluated as a rescue device in a multiplace setting. It allowed all patients in that study to equalize successfully.
But there's a catch, right?
Yeah, a crucial practical limitation. This device is battery-powered, which is not safe for use in an oxygen-rich monoplace chamber due to the risk of ignition.
Right. absolutely not. Any others?
Another promising device mentioned is a tympanometry-based system that measured eardrum pressure in real time and automatically adjusted chamber compression speed. Studies showed 0% IBI incidence with the device versus 32% in controls in a multi-play setting.
Sounds great, but
But again, this device contains electrical components, making it unsafe in a monoplace chamber compressed with oxygen.
so the clinical reality is that while automated devices show promise in multi-place or air-filled environments, current safety constraints mean they aren't a solution for monoplace chambers.
Pretty much. Patient education on maneuvers like the Valsalva and potentially managing underlying conditions like URI or allergies remain the primary strategies for MBA prevention in that setting.
Okay. Moving beyond the ears, the next subsection covers barotrauma affecting the sinuses and teeth.
Right. The paranasal sinuses are air spaces connected to the nasal passages. Similar to the middle ear, the mechanism of barotrauma involves obstruction.
So like a cold or allergies can cause swelling that blocks the connection.
Exactly. That creates an enclosed airspace. With pressure changes in the chamber, this can lead to barotrauma. The source notes this can occur during compression, that sinus squeeze, or during decompression as air expands. Patients report pain and sometimes epistaxis or nosebleed.
How common is this in HBO2?
Sinus barotrauma is considered low incidence in HBO2 patients. The published data is limited, primarily coming from scuba divers who experience different pressure profiles. The source cites an HBO2 study in traumatic brain injury patients with an incidence of just 0.14%, contrasting it with a diver survey reporting 35% incidence. Quite a difference.
Yeah. So how do we prevent it?
Prevention is straightforward. Avoiding HBO2 during an acute upper respiratory infection is the primary advice. If treatment is urgent, using nasal sprays like fluticasone or oxymetazoline for allergic rhinitis or managing URI symptoms might be considered, as the source suggests.
What about dental barotrauma, barodontalgia?
That's described as theoretical and uncommon in HBO2 literature. The source mentions a theory involving dentin permeability, but the key clinical point is that it almost always requires pre-existing dental pathology. A poorly sealed filling, a cyst at the root, or a cavity that traps air within the tooth.
So it's usually an underlying dental issue.
Exactly. It was first reported in air crews and divers, not primarily HBO2 patients. Patients feel pain in the affected tooth with pressure changes. Incidence in HBO2 is extremely low. A study cited specifically looking at HBO2 side effects found no cases of barodontalgia. Even in the diver survey, incidence was only 9.2%.
And if it happens?
The management is simple. If it occurs, the patient needs evaluation by a dentist to fix the underlying issue.
All right, finally, let's address pulmonary barotrauma, or PBT. Back to Boyle's law again.
Yes, again, Boyle's law is the governing principle. Air volume expands as pressure decreases, which is relevant during the decompression phase.
So the lungs expand during decompression.
Right. In HBO2, the lungs contract during compression and expand during decompression. The source states that with normal lungs and an open airway, there's typically no risk of PBT. The danger arises when the system is blocked by air trapping or a prolonged closed glottis during decompression. This leads to pulmonary overinflation.
And that overinflation can tear the lung tissue.
Precisely. Pulmonary overinflation can cause delicate lung tissue to tear, allowing air to escape into the interstitial spaces. Where that air goes determines the clinical manifestation.
Okay, where can it go?
Air can dissect along the airways to the center of the chest, causing pneumomediastinum. It can continue up into the neck and face, resulting in subcutaneous emphysema. Or it can enter the pleural space around the lung, causing a pneumothorax.
What are the symptoms for those?
Clinical presentations include chest pain, shortness of breath, and cough for pneumomediastinum, or neck swelling, pain with swallowing, and that crackling feeling under the skin for subcutaneous emphysema.
Crepitus.
Right. Pneumothorax also presents with chest pain and difficulty breathing, along with absent breath sounds on exam. And attention pneumothorax is a life-threatening emergency where pressure builds, compressing the heart and causing shock and death if not treated immediately. The source notes these are rare but reported occurrences in HBO2.
And the most serious consequence is arterial gas embolism, AGE.
Yes, this happens if air from the ruptured lung tissue enters the pulmonary blood vessels. While a known risk for divers, the source emphasizes it has been reported even after routine HBO2 treatments.
So how does that happen?
The pathway is overinflation, air into lung capillaries. Air travels to the left side of the heart, then can embolize anywhere in the systemic circulation, often the brain.
And the symptoms? Neurological mostly.
Symptoms are varied, especially neurological. Confusion, speech problems, weakness, vision changes, seizure, or even immediate loss of consciousness and cardiac arrest in severe cases.
Ugh.
Recognizing this varied neurological presentation is key.
How do we manage these PBT issues?
Management depends on the specific manifestation.
Uh-huh.
Subcutaneous emphysema and pneumomediastinum are usually treated conservatively with observation and supplemental oxygen. A pneumothorax might require a chest tube. However, if AGE occurs as a result of PBT, emergency HbO2 is indicated.
Right, treating the complication of the treatment.
Exactly, you recompress the gas bubbles.
Who is most at risk for PDT?
Patients at increased risk for PBT include those with underlying lung conditions causing air trapping, COPD or asthma with active bronchospasm, mucus plugging, pulmonary fibrosis, bronchiectasis, cysts, granulomas, tumors, or anything causing a prolonged closed glottis during decompression, like a seizure which links back to CNS O2 toxicity risk.
But despite this list, PBT is very rare in HbO2.
Extremely rare. The source states PBT in HbO2 is an extremely rare occurrence. It cites a study of over 62,000 treatments where only one case of PBT was observed. That really quantifies just how uncommon it is in practice.
Still, we need to screen for it.
Absolutely. The source requires patients to be screened for these risk factors using history, physical exam, and potentially imaging. Treatment can then be tailored based on individual risk.
Okay, let's do a quick micro recap on pressure effects. Boyle's law is key. Middle ear barotrauma is common, usually manageable, but watch intubated patients and those with neuropathy. Sinus dental issues are less common, often linked to underlying problems. Pulmonary barotrauma is rare but serious. Risk of AGE needs screening and specific management, including emergency recompression for AGE. And teaching equalization is crucial.
That covers it nicely. Ready to shift gears to hyperoxia.
Yes, let's move to the second major category of side effects detailed in the source, those caused by the effects of hyperoxia.
As we established, HbO2 involves breathing 100% oxygen at elevated pressures. The physiological result at standard treatment pressures, say up to 3 ATA, is a dramatic increase in arterial and tissue partial pressure of oxygen, or PaO2.
The numbers are striking. The source notes arterial PaO2 can exceed 2,000 millimeters of mercury, and tissue PaO2 often reaches 400 millimeters of mercury or more. These are profoundly supraphysiologic oxygen levels.
And as discussed earlier, these high PaO2 levels drive both the primary therapeutic effects and the secondary effects involving reactive oxygen and nitrogen species. But inevitably, these same high levels are the source of potential oxygen toxicity.
But our bodies can usually handle it at typical treatment pressures.
Generally, yes. The source offers reassurance. Our body's antioxidant defenses are generally sufficient to prevent significant oxygen toxicity at the pressures typically used for HbO2 treatments. Consequently, oxygen toxicity resulting from these reactive species is considered rare during routine HbO2.
Okay, what are the main ways oxygen toxicity can manifest?
We'll discuss the specific clinical presentations as presented in the source. Central nervous system, pulmonary, and ocular effects. Starting with subsection 3.1, central nervous system, or CNS, oxygen toxicity.
What's the mechanism there? How does high oxygen affect the brain?
The source explains the cellular mechanism. Reactive oxygen species and free radicals interact with the neuronal cell membranes, causing lipid peroxidation. This damage alters the brain's electrical activity. You can sort of visualize those reactive molecules damaging the fatty components of brain cell walls.
Is anything else involved?
Nitric oxide, or NO, is also a suspected mediator, potentially contributing via the formation of peroxynitrite and having direct vasodilatory effects that might counteract the body's attempt to constrict cerebral vessels in response to high oxygen. The source specifically notes that older theories involving intense cerebral vasoconstriction or carbon dioxide retention do not appear to play a significant role.
And the main symptom is seizure.
The primary clinical manifestation, as identified by Paul Burt way back in 1878, is a seizure. Developing a seizure requires sufficient PaO2 and exposure time. The source notes the relationship is inverse higher. PaO2 requires shorter exposure to reach the threshold for toxicity.
Are there usually warning signs, prodromes?
While many expect warning signs, the source points out that preconvulsive symptoms are inconsistent, appearing in less than 50% of cases. However, patients might report sweating, anxiety, auditory or visual disturbances, dizziness, nausea, or facial twitching. As clinicians, it's worth being alert for any of these subtle clues, though their absence doesn't guarantee safety.
So it can just happen suddenly.
It can. The seizure itself is typically a generalized tonic-clonic seizure. It can come out of nowhere or follow those subtle symptoms. The key clinical action described by the source is that the seizure is terminated by decreasing the inspired PaO2. specifically by switching the patient's gas source from 100% oxygen to air.
Switching to air stops it. Does it cause lasting damage?
This immediately lowers the oxygen partial pressure reaching the brain, resolving the seizure. Crucially, the source states that no residual neurological problems occur after a hyperoxic seizure. That's a significant reassuring point.
How often does this happen? What's the incidence?
Incidence is very low, typically reported per treatment. Earlier studies put it at 0.01–0.02% of treatments. More recent studies, according to the source, suggest a slightly higher range, 0.03–0.06% of treatments.
Okay, still very low per treatment. What about per patient?
Right. When you look at incidence per patient across the course of treatment, it appears higher, around 0.30–0.6% of patients, although one outlier reported 1.1%. The takeaway here is that while rare on any single dive, the cumulative risk to an individual patient over many treatments is slightly higher than the per-treatment rate might suggest.
Are there specific risk factors we should know?
Yes. Acute carbon monoxide poisoning is highlighted as an independent risk factor, with incidence reported as high as 1.8% in that population.
Wow. Why is that?
The theory is this relates both to the CO's direct effects and the higher pressures often used for CO treatment. So, be particularly vigilant for seizure risk in CO patients.
Makes sense. Others.
Higher treatment pressures themselves are associated with increased incidence, suggesting a dose response. A history of CNS abnormality, such as prior radiation injury, tumor, or traumatic brain injury, are also identified risks. Fever and hypoglycemia are further risk factors. The source suggests considering withholding HbO2 in a febrile patient.
Does the number of treatments matter?
Interestingly, no. The source notes there seems to be no relationship between the duration of a single treatment or the total number of treatments in seizure risk.
How do we prevent it then?
Prevention strategies primarily involve using air brakes during the oxygen exposure. Using a lower therapeutic pressure, when appropriate for the indication, can also reduce risk. Patients with epilepsy should ideally have their anti-epileptic medications optimized, though this isn't always possible in emergencies. Protocols to prevent hypoglycemia in diabetics are also warranted, which we'll discuss further. Most importantly, patients should be monitored closely, and if prodromal symptoms appear, immediately switch them to air.
And if a seizure does happen, switch to air.
Switch to air. That's the immediate response. It decreases the oxygen load to the brain and resolves the seizure. A critical safety point the source emphasizes. Do not decompress the chamber until the seizure has stopped.
Why not? Seems counterintuitive, maybe.
Attempting decompression during a seizure could lead to glottic closure, trapping air in the lungs, and risking pulmonary barotrauma. You'd be solving one problem, but potentially creating another, much more serious one.
Got it. Don't decompress during the seizure. What about future treatments?
Post-seizure, the source notes that an episode of hyperoxic seizure is not a contraindication to future HbO2 treatments. Recurrence is rare, and patients typically tolerate subsequent dives well. However, tailoring future treatments, perhaps using a lower pressure or incorporating more air brakes, is warranted based on the event.
Okay, that covers CNS toxicity. What about the lungs? Pulmonary oxygen toxicity.
Right, subsection 3.2. This is described as insidious in onset, meaning it develops gradually, but it can progress in severity, potentially leading to severe hypoxemia and, if unchecked, death.
What actually happens in the lungs?
The source details the pathological changes in the lung response to oxygen in two overlapping phases. The acute exudative phase involves initial damage, interstitial and alveolar edema, bleeding, fibrinous exudate, and damage to the cells lining the air sacs and capillaries. You can picture this as the lung tissue becoming inflamed, leaky, and damaged.
And the second phase?
This progresses to the subacute proliferation phase, characterized by attempts at repair that can lead to interstitial fibrosis or scarring, and an increase in type 2 alveolar epithelial cells, which are involved in surfactant production.
Does it depend on the dose?
Yes. The severity and specifics of these phases depend on the oxygen concentration, the duration of exposure, and individual susceptibility.
How does it affect lung function?
Pulmonary oxygen toxicity also negatively impacts lung mechanical function. Vital capacity, or VC, progressively decreases during continuous oxygen exposure. This reduction can continue for a few hours after stopping oxygen, but recovery typically occurs within a few days to weeks.
What about other measures? FEV1.
FEV1 and FVC, measures of how much air you can forcefully exhale, also decrease during continuous oxygen breathing at pressures like 1.5, 2.0, and 2.5 ATA. The longer the exposure at a given pressure, the greater the decrease. The source gives timings where significant drops were seen, like within 5–12 hours, depending on the pressure. Importantly, the source notes that significant air trapping was not seen in these studies.
And diffusion capacity, DLCO.
Diffusion capacity of the lungs for carbon monoxide, or DLCO, also decreases. The source gives an example, a 10.8% decrease after 13 hours at 1.5 ATA, and it decreased at all measured times at 2.0 and 2.5 ATA. Recovery of DLCO takes longer than VC recovery, often lasting over a week.
Does that mean low oxygen levels in the blood?
Not necessarily initially. The clinical implication noted is that these DLCO changes can occur without significant impairment in arterial oxygenation initially.
What are the symptoms a patient might feel?
Clinical symptoms include substernal burning, cough, chest tightness, and shortness of breath. These symptoms worsen with longer exposure, but resolve quickly, typically within 1-3 days after stopping oxygen. The onset timing depends on the pressure, occurring within 3-16 hours depending on the ATA. The source notes that at the highest pressures, CNS oxygen toxicity often limits the duration of the dive before pulmonary symptoms become severe.
But is this something we typically see with standard HbO2 treatments?
No, and the source provides a crucial reassurance regarding pulmonary oxygen toxicity with routine HbO2.
Well,
It is not expected from standard daily hyperbaric treatments.
okay.
While symptoms are possible with very long treatment tables, like some U.S. Navy tables, they would be mild and self-limited. The source emphasizes that proper oxygen dose titration can mitigate or eliminate this risk. It cites exposures that didn't cause toxicity. Therefore, the source concludes that current standard HbO2 applications generally do not cause clinically significant pulmonary functional deficits. This is important information for clinicians using standard protocols.
That's very reassuring. Okay, let's move to subsection 3.3, covering ocular side effects also related to hyperoxia. The first, and a relatively common one, is myopic shift, progressive nearsightedness.
Exactly. The most likely mechanism is oxidative stress causing alterations in the structure of the eye's crystalline lens. Strong evidence for a lenticular etiology, meaning it's the lens changing, comes from studies showing these refractive changes occur only in eyes with the native lens, phakic, and not in eyes with an artificial lens implant, pseudophakic.
So it's definitely the lens, not the cornea or something else.
That's what the evidence strongly suggests. Studies have found decreases in light scatter and optical density within the lens media, suggesting changes in the material of the lens, not its shape or the shape of the cornea.
Does how we give the oxygen matter? Mask versus hood.
Yes, the mode of oxygen delivery significantly impacts the risk. Oxygen delivered via hood or in a monoplace chamber where the eye is exposed directly to high concentration. Oxygen at pressure has a poorer ocular outcome and results in a greater myopic shift compared to oxygen delivered via an oronasal mask in a multiplace chamber, where the eye is exposed primarily to air at pressure.
Direct oxygen exposure to the eye is the key.
Seems to be. The source quantifies this difference in direct oxygen exposure to the eye in kilopascals, much higher with hoods or in monoplace chambers.
How common is this shift?
Estimated incidence of at least a one-line change in vision is around 60%. The shift is progressive throughout treatment, averaging about 0.25 diopters per week. But severity varies greatly among patients. It's a function of exposure, duration, pressure, and oxygen delivery method.
Can we prevent it?
Prevention strategies based on the oxidative mechanism involve reducing direct oxygen exposure to the eye. This includes using air breaks during treatment, using an oronasal mask if available in multiplace, or potentially using lower pressures.
Is it permanent?
Importantly, no. These myopic changes are typically transient. They resolve spontaneously, usually within 6 to 10 weeks after completing treatment, though it can take up to 6 to 12 months. Setting realistic expectations for patients is key here.
Okay. What about cataracts?
Next, cataracts. These involve yellow-brown discoloration and haziness of the lens, reducing visual acuity. Oxidative stress on lens components is thought to be a central mechanism, particularly affecting the lens nucleus due to lower antioxidant levels like glutathione. Oxidized glutathione leads to protein changes and light scattering.
Does standard HbO2 cause cataracts?
While cataractogenesis is a potential side effect, the source notes it's been seen after very high cumulative exposures, typically 300-850 hours. One study found new nuclear cataracts in 7 out of 15 patients after such exposures.
So not with a typical course of, say, 30 or 40 treatments.
Exactly. The source mentions a single case report of cataracts after a standard course, 48 treatments, but explicitly states that new cataracts are not expected to arise de novo with standard regimens of 20-60 total treatments. However, a crucial point is that progression of existing cataracts is possible.
Okay. Progression is possible. New ones are unlikely with standard doses. Got it. Finally, retinopathy of prematurity, ROP.
Yes. This is a developmental vascular disorder in the retina of preterm infants. Key risk factors are prematurity and increased PO2.
How does high oxygen cause ROP?
The mechanism involves high PaO2, causing vasoconstriction and suppressing growth factors like IGF-1 and VEGF. This stops normal retinal vessel development and destroys existing capillaries, leading to retinal ischemia. The subsequent hypoxia then triggers abnormal, disorganized vessel growth.
I know there's debate about oxygen targets for preemies.
Right. The source briefly touches on the clinical debate about optimal oxygen saturation targets in preterm infants, noting it's complex and involves balancing ROP-BPD risk from hyperoxia against risks like CP neck death from hypoxemia.
So what's the relevance to HbO2?
The relevance to HbO2 is that it generates arterial PaO2 levels far exceeding the ranges debated for preterm infants. Thus, the source states that such high partial pressures could theoretically increase ROP risk in this population.
Theoretically?
Yes, this is presented as a theoretical concern based on known ROP pathophysiology and HbO2's effects on PO2, not as evidence from studies showing HbO2 causes ROP in this specific population based on the provided text.
Okay, quick recap on hyperoxia effects. High O2 can cause toxicity, though rare with routine dives. CNS means seizures. Rare, CO is risk factor, use air brakes. Manage with air, not decompression. Lungs, insidious changes, not expected with standard protocols. Eyes, common transient myopia, lens-related, worse with direct O2. Rare new cataracts with standard doses, progression possible. And theoretical ROP risk in preemies.
Well summarized. All right, let's move into the final section, covering other important considerations not strictly categorized under pressure or hyperoxia effects, as discussed in the source.
First up is claustrophobia. The source classifies it as a specific phobia, characterized by significant fear or anxiety disproportionate to the actual danger.
The triggers are, predictably, confined spaces like hyperbaric chambers, MRI scanners, elevators, tunnels, etc. While about 2% of the general population report claustrophobia, anxiety during MRI scans is much higher, maybe 35%.
How common is it in HbO2?
Incidence in HbO2 varies. A multiplace study found low incidence of confinement anxiety, 0.3%, but another in multiplace reported 4.3% of patients experienced it, leading to 1.3% discontinuing treatment. A monoplace study also found a similar rate, 3.3%. Differences likely relate to how it's defined and measured.
How do we help patients deal with it?
Mitigation is crucial. Patient education and coaching, both before and during treatment, are primary methods. Familiarity with the chamber over the course of treatment also helps reduce anxiety. For severe cases, the source notes that mild pretreatment sedation may be required for patients to successfully complete the treatment course. This is a practical tool for managing this barrier to therapy.
Okay, next up section. Blood pressure effects. HbO2 raises blood pressure.
Yes, the source states that HbO2 causes increases in both systolic and diastolic blood pressure, observed in patients with hypertension and those who are normally normotensive.
Why does that happen?
Proposed mechanisms for this post-HbO2 rise include hyperoxia-induced peripheral vasoconstriction, leading to increased resistance in the blood vessels. The source also mentions studies showing increased endothelin-1, a potent vasoconstrictor, after HbO2, and decreased urinary PGE2 in dogs, which might attenuate vasodilatory prostaglandins.
Is it a big increase?
The impact is generally mild, with reported increases ranging from 6% to 31%. Factors associated with higher increases include the use of calcium channel blockers and beta blockers, and a history of hypertension or diabetes.
Does it get better or worse over a course of treatment?
Interestingly, studies conflict on whether blood pressure changes over a full course of treatment. One study found smaller rises with successive dives, suggesting adaptation, while another saw consistent increases. The source concludes that further research is needed to clarify the long-term effects of HbO2 on blood pressure across a treatment series. This remains an area of uncertainty.
Okay. Next up, cardiogenic pulmonary edema, CPE. Fluid in the lungs from the heart. Does HbO2 cause this?
The source explicitly states that acute pulmonary edema is not expected in patients with normal cardiac function undergoing routine HbO2.
Ah, so it's a risk for patients with existing heart problems.
Exactly. The risk is specifically in patients with severely compromised left ventricular function, or LVF. HbO2 itself decreases heart rate, increases systemic vascular resistance, and decreases cardiac output, primarily due to the slower heart rate, according to one study cited.
Are there other ways it might trigger CPE in those patients?
Other proposed mechanisms for CPE in already compromised LVF include increased pulmonary capillary wedge pressure or interference with heart muscle function by reactive oxygen species.
How often does this happen?
Acute CPE is rare in HbO2 patients. Published incidence is limited, but studies report rates around 1 in 1,000, 0.1%, or 1 in 4,500, 0.02%, plus case reports.
What's the clinical bottom line here?
Clinical implication. While not expected with normal LVF, it can occur in those with severely impaired function. The source advises obtaining recent echocardiogram results, including ejection fraction, EF, for patients with a history of congestive heart failure. Caution is warranted in patients with a low EF, specifically less than 35%.
So check the EF. What if it's low?
The source gives clear advice. Avoid HBO2 if the patient is fluid overloaded. Supine positioning in a monoplace chamber might be an additional risk factor for these patients. For those with severe EF less than 35%, the source suggests considering treatment in a multiplace chamber, where they can sit upright and have immediate attendant access. This is a practical risk reduction strategy based on chamber type and support.
Good practical advice. Okay, subsection 4.4 addresses hypoglycemia in diabetic patients. I know centers worry about this.
They do. Hyperbaric medicine programs commonly have protocols to prevent hypoglycemia in diabetic patients, but there's no standardization. Cutoffs for pretreatment blood glucose vary widely, from 100 to 170 milligrams per deciliter, with 120 being common.
What's the thinking behind those protocols? Does HBO2 cause low blood sugar?
Well, the prevalent theory is that HBO2 causes hypoglycemia, perhaps by stimulating insulin. However, the source reviews the literature and finds limited data to strongly support this direct effect or a clear mechanism. Animal and small human studies haven't definitively confirmed it. A direct HBO2 effect on blood glucose remains theoretical, according to the source.
Really? So the protocols might be based on a shaky theory. What does the clinical data actually show?
Studies looking at blood glucose levels in diabetics post-HBO2 show high variability, with many patients actually seeing an increase in BGL. Critically, there's a consistently low incidence of clinically relevant symptomatic hypoglycemia and no poor outcomes reported in these studies.
So lots of variability, but few actual symptomatic lows.
Exactly. While mean BGLs might decrease post-dive in some studies, there's a huge range, and many patients' BGLs increase. Hypoglycemia less than 70 occurred in about 1.5% of treatments in one study, but only 0.19% were symptomatic. And a crucial finding highlighted. Well-controlled diabetics, those with stable pre-dive BGLs, had no post-dive BGLs below 70 or 90.
So good control protects against significant drops.
It seems so. The implication is that many protocols might have minimum pre-HBO2 BGLs that are too high. An overemphasis on hypoglycemia risk could cause patient overcompensation, eating too much before the dive, leading to poorer glycemic control overall.
Which kind of defeats the purpose, since good control helps healing.
Precisely. HBO2 is adjunctive to standard care, which includes tight glycemic control. Overcompensating and losing control can undermine the very healing process HBO2 is meant to support. The source suggests institutions might consider tiered protocols based on a patient's typical glycemic control level, a lower minimum BGL for well-controlled diabetics, a higher one for poorly controlled ones.
That sounds like a more evidence-based approach. Okay, finally, subsection 4.5 covers potential interactions with bleomycin and doxorubicin chemotherapy drugs. What's the concern with bleomycin?
With bleomycin, initial animal and early human studies suggested a synergistic effect with high oxygen, potentially increasing pulmonary toxicity.
But newer studies contradict that.
Yes, the source highlights that subsequent clinical studies have questioned or refuted this synergistic effect. Studies administering HBO2 safely to patients with a history of bleomycin, even relatively soon after, like months after, found no evidence of pulmonary oxygen toxicity.
Okay, what about doxorubicin?
For doxorubicin, one animal study showed increased mortality with concurrent use and HBO2. But the source stresses no toxic effects have been reported in human clinical use.
So what's the final recommendation? Can we treat patients with a history of these drugs?
The clinical conclusion from the source is clear. A history of either bleomycin or doxorubicin is not a contraindication to HBO2. However, out of an abundance of caution, based on the animal data, it is recommended to avoid concurrent use.
Avoid using them at the exact same time. What about timing? How long to wait?
Timing guidelines, also offered out of caution and noted as likely being safe sooner. Doxorubicin can be started within days of HBO2, and bleomycin may be 6 months after. The source explicitly states this is extra cautious and likely safe sooner.
Any specific monitoring needed?
For patients with a history of bleomycin and pre-existing pulmonary disease, the source pragmatically suggests considering baseline pulmonary function tests and monitoring during HBO2.
Okay, let's micro-recap this final section. Claustrophobia, common, manageable. Blood pressure, mild increases, conflicting trend data. CPE, rare, risk tied to low EF, screen EF, Consider multiplace. Diabetic hypoglycemia theory shaky, symptomatic events rare, consider tiered protocols. Chemo history, okay, avoid concurrent use, cautious timing guidelines.
Nicely done. Well, we've really delved deep into the potential side effects described in this expert source, systematically covering those linked to pressure, hyperoxia, and other factors.
It truly underscores that while HBO2 offers significant therapeutic benefits, a thorough understanding of potential risks is paramount for safe and effective practice.
And while the list of potential side effects is long, it's reassuring to note that based on the data presented in this text, the more severe manifestations, things like tympanic membrane rupture, arterial gas embolism, clinically significant pulmonary oxygen toxicity, new cataracts with standard doses, or cardiogenic pulmonary edema in patients with normal heart function are generally rare occurrences.
Bringing together the key clinical takeaways for you, the specialist clinician. Patient selection and meticulous screening are absolutely vital. This means actively assessing risk factors like eustachian tube dysfunction, whether a patient is intubated, presence of neuropathy, underlying lung, brain, or heart conditions, active infection, diabetes status, and prior chemotherapy history.
And patient education is equally critical, teaching equalization maneuvers, setting realistic expectations about things like transient myopic shift. Understanding the underlying mechanisms helps predict and manage potential issues.
Specific mitigation strategies like using air brakes for oxygen toxicity risk, carefully considering pressure or compression rate while acknowledging some conflicting data, implementing tailored protocols for diabetic patients based on their control, and following timing recommendations for chemotherapy are all tools in your clinical toolbox.
And knowing how to recognize and immediately respond to acute events like a hyperoxic seizure switch to air, don't decompress, or potential manifestations of pulmonary barotrauma, including the specific emergency management for AGE, is essential for patient safety.
Absolutely.
And finally, appreciating where the evidence is strong, like the reason for myopic shift, the clear risk in intubated patients for MAB, or the rarity of serious PbTO2 toxicity with standard protocols, versus where there's more uncertainty or conflict in the data, such as optimal compression rates, or the exact link between HBO2 and diabetic hypoglycemia, empowers you to make more informed decisions and manage patient expectations effectively.
So given all the complexities we've unpacked today, the variability in study findings for incidence, the conflicting data on things like compression rate optimization or the direct impact on diabetic blood sugar, and the theoretical risks identified, what specific questions about hyperbaric side effects are most critical for our field to answer with rigorous research to further refine our protocols and truly maximize patient safety?